Learn what you can do to prevent burn injuries and protect your family. Up next on the Giblin Report. Welcome to the Giblin Report. I'm Assemblyman Tom Giblin, representing the 34th Legislative District, which includes Clifton, East Orange, Montclair, and Orange. On today's segment, I am pleased to welcome Kathy M. Conlon, Director of Community and Disaster Programs at St. Barnabas Burn Center, and our colleague, Medical Director, Dr. Michael A. Marano. Welcome to the Giblin Report. First of all, we'll start the St. Barnabas Burn Center. Kathy Conlon, how did it all come about and how long has it been in existence?
Well, the Burn Center has been in existence since April of 1977. Up until then, there was no dedicated burn treatment facility for New Jersey, but the hospital was the recipient of a grant, and we were able to open our doors. And interestingly enough, our very first patients came from a mass casualty incident in the city of New York, where they had a big explosion, and 5 of the 15 were airlifted over to New Jersey.
You know, Dr. Marano, first of all, how long have you been associated with the St. Barnabas Burn Center?
I've been at St. Barnabas now for 26 years. I came in 1993 to join the burn group, and it's been a very rewarding experience, very excellent group.
You know, folks that are listening to today's program, if they experience a burn injury, why to St. Barnabas Burn Center versus another neighboring hospital or healthcare facility?
The main reason is that practice makes perfect, and there are 128 burn centers in the United States, and all of us work under the same general situation where we have a multi-center approach, multi-specialty approach to burn care. And just like any other type of medical care, the more that you do something, the better you get at it. And so we are the burn center for the state of New Jersey, and we have the individuals that are specially trained in various aspects of burn care to do the best job possible.
I assume that's kind of an ongoing issue about quality care, because you're constantly learning new techniques or treatments, or maybe you have a certain type of applications you can use to deal with the healing process.
Yes, that's right. And in fact, the entire genesis of burn centers in the nation, pertinent to your first question, is that it was after, I would say, after the moon landing in the late 60s, that technology just became very much more advanced. And around the country, life support systems came into being, like kidney dialysis, for example, and open heart surgery, and critical care type management. And once those life support systems came into effect, now we're into the mid-late 1970s, that's when burn centers started developing across the country, because those technologies were then available. Well, new technologies continue to be developed, and now they're more biomedical technologies, artificial skins, for example, and those sorts of things. And at burn centers, there are clinical trials across the United States, and we're involved in that sort of enterprise, and it's going to push the science forward, and hopefully people in the future who suffer burn injuries will have much better options than they've had in the past.
Kathy Conlon, reading your biography, I note that you're a graduate of Seton Hall University. I assume you got your BSN degree from Seton Hall?
Yes, I did. I graduated nursing school, and it was the best decision I ever made.
Why did you wind up, being affiliated with the Burn Center for so long? Are you almost there from the early days? Kind of, it sounds like it.
I am actually one of the last original members. Interestingly enough, nursing is a second career for me. I had a degree in education. And,
were you a school teacher?
Well, I had the degree. I never actually taught in school because there were not a lot of jobs available. So I was working at the hospital, and the burn center was just getting ready to open. And as I said, those patients were flown in from New York. And when I saw these critical burn patients, I made the decision then to go back to school and pick up my science and clinicals at Seton Hall and complete a nursing degree. So that's how I transitioned down to the burn center.
I read some information going back about turnover in the burn center, that it's not a job for the faint of heart. I'm talking about, the nurses, because, they see some difficult challenges, and, they maybe just can't take it, so to speak, because, the patients go through, a lot of challenges and rigor and, in terms of the healing process. So, what makes your longevity so significant? How are you able to overcome that? If, in fact, is there a high turnover as far as, staff and nurses are concerned?
I think in our unit we're pretty lucky. The staff turnover is relatively low, and I think that's due to a couple of reasons. The first and foremost is the people who come into the burn center truly, really want to be there. I also think, too, that we're very fortunate, as Dr. Marano mentioned, we utilize a multidisciplinary team approach of care. So the nurses have a great deal of responsibility and autonomy. We can actually practice at a higher level in our burn center than we do in other places. And then I think the one piece of burn care that's often underappreciated is we have the opportunity to see our patients come full circle. So while they will come in severely injured and it's a very devastating experience, what makes it joyful for the staff is when you see them go home, go on to lead normal, productive lives,
and come
back
to
and visit us. They'll come for outpatient, and they always come upstairs. And sometimes we don't always recognize them because they're not as disfigured anymore, and they've grown, especially the children. But it really, truly is a joyful experience.
With your patients, how do you get them? Do you get them from other healthcare facilities who might realize they can't give the care that the burn center provides, or are they self-referrals, or just people from the neighboring areas? You run the gamut as far as getting people from all over the state in the region, pretty much, right?
Well, it's a little bit.
You got the reputation, so you're almost like kind of a victim of your success because you've done such a spectacular job in terms of treating burn wounds, right?
We do really try to make sure that everybody understands the importance of getting to a burn center. And as Dr. Marano just explained, we have a very diverse community outreach program where we partner with our first aid squads, our paramedics, our emergency departments, and either the nurses or the doctors will go out and we provide educational awareness. It's also word of mouth. And then sometimes, often the physician at the local hospital will start to take care of a patient and then realize the complexity and that there's more to recovering a burn patient than just the wound, and they'll call the burn center, and then one of our physicians will facilitate the arrangement.
Dr. Marano, a patient stay, I mean, I'm sure it's not a, come up, put a Band-Aid on, you're out the door, or even a couple of days. A lot of times these are very extensive stays. So, would you be able to recount, the shortest or the longest, so to speak, as far as some of your typical patients are concerned? I know going back, we had an unfortunate issue at Seton Hall University some years ago. I don't know if you were at the burn center then, but that was a major challenge in terms of getting those students and folks at Seton Hall back on the road to recovery. So what's the typical stay of a patient?
Yeah, it's a very good question. It would depend on the extent of the injury, whether or not the patient has smoke inhalation, for example. It also will depend on what pre-existing medical conditions the patient might have. So when patients come in, they're essentially triaged into burn patients that need to come into the hospital but don't necessarily need intensive care. And the other group would be those that definitely need to be on life support, for example, and in the burn intensive care section. My general rule, not counting the smoke inhalation, is 1 day in the hospital for each % burn. So if you come in with a 20% burn, you're probably going to be with us for 3 weeks, as a very generic kind of rule. There are other factors, of course, that might cause a person to need hospitalization for longer, and that would be organ system dysfunction, organ system failure, infections, the need for multiple operations, or if they have those smoke inhalation injuries. Those will all increase the amount of time that someone needs to be in the hospital. So therefore, if you take someone who has a 50% burn, they're going to be with us for 3 or 4 months.
What about this issue where people, get a burn and they got this mindset, well, I got a home remedy that I heard about that, will fix that up right away, or I'll apply it for 3 or 4 days. How do you kind of get around that in terms of trying to dispel that notion I can, fix it myself?
I'll try to answer that. Maybe Kathy has something to add, but that would, if it's a relatively small burn, I would say most people will reach for whatever they can find in the area where the injury occurred. So if it's in the kitchen, they're probably less injurious things that people can apply than if they're in the garage. So I would say most people will reach for the refrigerator and pull something out that's cool.
Ice or something like that? Or
Yes. One needs to be careful about ice because ice can cause a deeper injury. Any particular
like infection or something?
If the patient already has a burn, let's say on their hand, and they're applying too much ice, it can anesthetize the hand and cause actually a frostbite on top of that. So I would say cool water for a small burn is a good place to start, some elevation, and then some first aid or a trip to the emergency room is not a bad idea. If the burn is larger, there are a whole different set of issues that come to play. So for example, if a person has an injury from having a seizure in a bathtub, they're going to have a more extensive burn, and therefore it would be not a good idea to immerse that person in a cold bath because their body temperature would drop.
Kathy, Conlon, the injuries that you encounter at the burn center, would you say most of them are home-based, or are they industrial settings where people get injured? Is it a lot from the home environment?
It tends to be a little bit more from the home environment. In the burn world, we say that the kitchen and the bathroom are the 2 most dangerous rooms in your home because you have heating issues, hot water, especially if there are young children in the home running around. So those tend to be the high-risk areas in the home setting. And then certainly there can be some issues with industry. We may see, for example, utility workers because of the risk that they have from electrocution and other types of exposures. It pretty much runs the gamut.
Yep. So, what's kind of the best treatment for a burn injury, Dr. Marano? Get to St. Barnabas ASAP, or if you can't do that, then is there anything that you should do on an immediate basis?
Right. If a person has a small burn, let's say a burn that occurs that involves a part of the hand, for example, a part of the forearm, something of that nature, some cool compresses would be a good thing, and a local emergency room can most likely handle that for the initial phase of the injury. It's very common for that institution to call us at the burn center to get some advice as to what the follow-up would be, for example.
Do they get infections from that?
Oh, sure. Yes. Definitely burns, even if they're small, can develop infections. And we are available 24/7 for advice. We look at ourselves as not only taking care of burn victims, but we're a public service for the state. So we'll get on the phone with anyone in any emergency department or a doctor's office or urgent center. If the person has a larger burn, then they need to get to the emergency room as quickly as they can, whether it's through EMS services or if someone can drive them. And then they're going to need to have fluid resuscitation and methods that are employed to prevent them from becoming too cold. And we're going to have to get involved much earlier in that patient's care.
Kathy, Conlon, is there any such thing as prevention of burns? I mean, I know that you enjoy a pretty good reputation among all the various fire departments. Everybody kind of knows your name, throughout, especially the northern part of the state. But is there really anything that you can do in terms of getting the message to the public about trying to minimize burn injuries?
Well, and one of the things that we say in the burn world is the best way to treat a burn is to prevent it. So we're very fortunate at the burn center. We have a lot of administrative support that allows us to have 2 full-time educators that really go out and cover the state. And we focus...
Where do they go? Schools or industrial sites? Or
well, we focus on 2 key areas. So it would be fire safety and prevention. Therefore, we would go into industry or to schools or to speak to adults on how to prevent burn injuries in the home, some basic minor first aid that they can do if an injury occurs, and how to access the burn center. Then we also...
Let's take one at a time. Industrial sites, I mean, sometimes that's... you can only do so much there because some of the, they might be involved in an explosion or, a very serious fire, and isn't the best thing just to get out of the area, so to speak, if something like that occurs, and leave it to the professionals to try to
something of that, something of that nature. If it's if it's a really catastrophic event, but a lot of industry, they have those plans in place already. This would really be for some of the smaller, so-called minor injuries that could have potential complications associated with them. So we will work with business and industry if they are at high risk and they've developed an escape plan or any type of education. Oftentimes we'll review those plans from a technical perspective. As you know from sitting on our board of directors, we work closely with public service. So we've actually worked with the PSE&G healthcare department to help them create a burn response plan.
Do you ever do anything like drills? Because, I think, for example, down in, say, the Newark Airport region and Dormitory Avenue, there's a lot of chemical plants along that corridor, like, say, we're not, even anticipating something, but like a, pretty significant disaster occurred. I mean, how you would, map it all out about trying to, set up a recovery operation. Is there any, or you leave that to the fire departments to figure it all out?
No, we partner with the fire departments and the EMS and the disaster agencies. You spoke of the Seton Hall Dormitory fire a few moments ago.
Was that one of your worst in your history?
It actually was the most catastrophic event. We ended up admitting 54 students in 2.5 hours that night. The second phone call that the South Orange fire chief made was direct to the burn center. And that really was due to previous partnerships and relationships that we had already established with the South Orange Fire Department. And interestingly enough, the lessons that we learned from that incident, we were one of the few burn centers that was better prepared a year later when 9/11 occurred.
Well, then some of the things out of that outgrowth, wasn't there issues of, I think, furniture and things like that might have had toxic fumes, or even the building materials that were in that dorm area? I don't know if that's something I remember seeing. Maybe, I'm not sure if I'm in the right direction, but I think were anything like that cause of the major casualties or injuries?
Well, one of the things that we do know is, especially working with our New Jersey firefighters, is they're starting to see an increase in cancer exposure and cancer risks, particularly among fire service. And they've been able to directly tie it back to the late 70s, early 80s, when a lot of fire retardants and with the institution of a lot more non-natural materials, so the plastics, the nylons, the rayons.
What I was getting at, yeah.
And we have learned in the burn world as well as in the fire service that these products burn much more hotter and are much more toxic. And unfortunately, everybody, but particularly our firefighters, are at greater risk. So we are starting to see a significant increase in the cancer risk in this population. As a matter of fact, Dr. Marano and I have been working with our oncology department at St. Barnabas. We're hoping to institute a brand new firefighter cancer screening program because of the relationship that we already have with our firefighters.
And how would that all work? You do an assessment and then follow up periodically to see how they're if they're moving in any negative direction, I guess?
Yeah, we would invite them to come and be screened, and then because we're a statewide healthcare system, we would then have the resources.
That would be volunteers and active
yes.
firefighters too?
Yes.
Thinking about this, the 9/11 disaster, was there any way, like, maybe you weren't directly involved, the burn center, but I'm sure a lot of people that you're associated with somehow during the course of that recovery might have been at that site, firefighters especially, or EMS folks. Was there any issues that cropped up out of that, like what you mentioned about the lungs and things like that could have had an impact? Was there anything in that area that you encountered?
Well, we do know that the firefighters who were at 9/11, particularly during the lengthy recovery process, have also had increased exposures to a lot of toxic chemicals. And many of them are being followed through the different studies, one that originates out of New York and another one that's based out of Piscataway through Rutgers University. So The burn center, obviously, we do try to promote health and safety with the firefighters just in general, but especially for those that were over in New York for any length of time so that they can be enrolled in these studies and be followed and have any issues addressed and addressed early on.
Dr. Marano, because you're kind of viewed in the top tier of burn center physicians, do your colleagues in other hospitals reach out to you to try to get your guidance or your expertise or your experience in terms of trying to help patients in their recovery? I mean, it seems to me like you got an awesome responsibility there, and your knowledge is invaluable because you probably have run the gamut as far as trying to treat all types of burn injuries.
Yes. On various levels at the state level, we are integrated into the trauma system, for example. So we know personally the trauma directors of the various institutions in New Jersey. We are on the phone with all of the hospitals in New Jersey, whether they're universities or community hospitals. And so we either know them on a personal basis or certainly have contacts for each other. And we'll get all the big burns in the state for the most part. Because of that. And it has to do with facilities and the commitment of the institution to provide all the services that are required. And so we have a very good relationship within the state. Within the region, Cathy has organized this Northeast region for communications for either disasters or for emergencies that goes from Maine all the way down to Washington, D.C. There's another set of communications that's involved with the centers in the Northeast region. And then nationally, we keep in contact with each other around the country and learn new things and really try to stay on top of our game so that we can provide the best care possible.
Cathy, about this Northeast region, what's the concept behind that? Have you really come into a monumental situation in that particular area that you needed all hands on deck to try to help people who faced burn injuries?
One of the things that we know in the burn world is burn patients will do better if cared for at a burn center. But as Dr. Marano mentioned early on, there are a limited number of burn centers. In the United States, there's less than 2,000 dedicated burn beds. And right now, 60 to 75% of them are already occupied. So when you're faced with a situation like 9/11, our burn center alone received a phone call that morning asking if we could accept 200 burn patients, which is very difficult because, again, as Dr. Marano said, if you're spending 1 day per percent burn, how do you care for 200 burn patients? So working with the American Burn Association, new disaster triage criteria has been developed that the burn centers are following. And one of the things that we did in the Northeast is, while we've always had a friendly relationship with our sister burn centers, we became a little bit more organized when we formed this consortium. And essentially, we reached out to these burn centers and asked if we in New Jersey got into trouble, would you commit to helping us out? And their response was yes, if you would reciprocate. So that's how the Northeast region was formed. And interestingly enough, it's been a model that has been developed and followed by other burn centers across the country. So there are now 5 regions in the United States with a 6th region in Canada. And as regional coordinators, we all cross-train and drill with one another on a regular basis. In fact, we're getting ready to do a big federal drill this August.
Doctor, it seems to me like in a burn center, the ratio of nurses to patients must be, fairly higher. Do you run into hassles from the insurance carriers about, trying to get treatment approved, or, I guess a lot of times you're dealing with some workman's comp, insurance companies or homeowners, things like that. So is that any type of barrier for, a recovery in terms of trying to work that out? Because, everybody always wants to second guess the medical professionals, is this care needed, or can we get a cheaper direction? I mean, and when they're seriously challenged like that, they need the best they can.
That's right. It's an excellent question, and there's so many intricacies to the whole system that it gets confusing at times. I would say the basic principle that we operate on is that we take care of everyone without regard to insurance and so forth or payment, there are a significant fraction of individuals we take care of who may not even be United States citizens. We take care of everyone. On the other side, though, looking down the line, once all the acute care is done, whether it's critical care or otherwise, there are resources that are necessary for rehabilitation, for example, and that can be a stumbling point because we cannot mandate that someone be allowed to enter a rehabilitation facility if they don't have the insurance. So it does make a difference what your rehabilitation potential will be more than your acute care based on whether you're workers' compensation or whether you have a private insurance or whether you have no insurance and so forth. But for the acute care, we treat everyone the same. I would also, the last thought I have on that is if we run into a very, very super expensive option, like using, for example, new materials, biomedical type materials, the institution, St. Barnabas, has stepped in many times and said to us, whatever you need to do to take care of the patient, we'll cover. And so that's how we've operated, and we're very fortunate to be in that environment.
Cathy Conlon, I know that education is a big component of the Burn Center. I have 11 grandkids. They're all, still fairly young. How did the program specifically about educating kids? I know you have a kind of a school bus of sort that goes out to the schools, and what's on that, and what do you do special? We only have a couple more seconds, but maybe at least tell us about that, and so we can get that across to the viewers of the Giblin Report.
We have 2 mobile fire safety house trailers that replicate a home environment, and we take them throughout the school system. We target 3rd graders, and essentially it's filled with hazards, and the children have to identify the hazards, and then we can fill it with a non-toxic smoke, and they have to find an alternate way out, and the local fire department, along with one of the Burn Center educators, helps deliver these programs.
How can people reach Dr. Marano or Kathy Conlon? Is there an email or a phone number, or just contact you at St. Barnabas and Livingston? What's the best way to reach you?
Well, if you need to contact somebody because of a medical emergency, the best number to call is 973-322-5920. That will get you direct into the burn intensive care unit and get one of the nurses or physicians if it's an emergency. If you're looking to schedule a fire safety house or a community program, 973-322-8071, or our website, www.newjerseyburncenter.com.
Okay, I just wanted to tell our viewers that if you have any pressing issues that require my attention or any matters dealing with current New Jersey legislation, you can reach me at 973-779-3125. You can also email me at asmgiblin@njleg.org. Additional information, you can go to my website, www.assemblymangiblin.com. Thanks for watching the Giblin Report. And remember, St. Barnabas Burn Center, Livingston, Dr. Michael Marano and Kathy Conlon are here to serve you and try to meet your needs. Thank you once again.